Every day, your kidneys filter an astonishing 200 quarts of fluid from your bloodstream. That is enough liquid to fill a large bathtub completely to the brim. Yet the average person only excretes about 2 quarts of urine in that same 24-hour period. Welcome to Super Nurse. This framework is built directly from the bedside knowledge of Brooke Wallace, a 20-year ICU nurse, organ transplant coordinator, and clinical instructor dedicated to translating dense pathophysiology into actionable nursing care. Reading about renal failure in a textbook often feels abstract and distant from the reality of the floor. But that abstraction disappears when you're standing in a patient's room and their urine output abruptly stops while the heart monitor begins showing dangerous, unstable rhythms. Today, we are decoding the renal system. We'll differentiate acute injury from chronic disease, translate the key labs, and map out the specific protocols for managing lethal electrolyte emergencies. Understanding this physiology allows a nurse to anticipate the data and recognize the patterns of a systemic crash before the patient decompensates. A helpful way to visualize the kidneys is to think of them as high-powered washing machines. For organs the size of a bar of soap, they are incredibly demanding. Commanding 25, this is the body's effort to actively pump stubborn, large molecule waste directly from the blood into the forming urine before it heads to the bladder. By filtering the entire blood volume constantly, the body is able to sample the blood and maintain a dynamic chemical homeostasis minute by minute. When this intricate filtration system loses power or sustains damage, we call it acute kidney injury, or AKI. AKI is defined by a sudden, massive drop in filtration accompanied by a spike in creatinine occurring over hours or days. Clinical experience divides failures into 3 categories. Prerenal means restricted flow before the kidney, leaving nephrons starving. Intrarenal is direct damage to internal mechanisms, often from nephrotoxic medications. Finally, postrenal is a structural backup, like a kidney stone, crushing nephrons with trapped pressure. While AKI is a sudden event, chronic kidney disease, or CKD, is the progressive, irreversible death of nephrons over months or years, ultimately leading toward end-stage renal disease. Identifying whether the failure is intra, or post-renal allows the nursing and medical team to target the specific root cause and attempt to reverse the damage. When filtration stops, the microscopic failure manifests as physical symptoms at the bedside. Without urine production, trapped fluid causes the pressure inside the vessels to skyrocket. This forces water out of the vascular space and into the surrounding tissues, creating pitting edema and bounding, forceful pulses. The most dangerous place for this fluid is the lungs. As hydrostatic pressure forces water into the delicate air sacs, the patient begins to struggle for air. This is heard through the stethoscope as crackles, the sound of air trying to pop open fluid-filled alveoli. Beyond fluid, we must also monitor metabolic trash. Uremia is the dangerous buildup of nitrogenous waste circulating continuously through the bloodstream. These toxins can cross the blood-brain barrier, leading to uremic encephalopathy. A patient who is lucid in the morning may become acutely confused, agitated, or lethargic by the afternoon. Monitoring urine output is the ultimate bedside assessment. We look for a minimum threshold of 0.5 milliliters per kilogram of body weight every hour. Because a weight gain of just 1 kilogram equals 1 liter of hidden trapped fluid, performing precise daily weights provides the same diagnostic weight as a complex lab panel. The most immediate clinical emergency in kidney failure is the rapid buildup of potassium, leading to severe hyperkalemia. Potassium dictates the resting electrical membrane potential of cardiac muscle cells. When levels climb too high, the electrical system of the heart becomes hyperexcitable and unstable. The warning sign of a heart moments away from a lethal rhythm is the peaked tent-like T wave on the monitor. We must intervene immediately. The first step is typically IV calcium gluconate. Calcium does not remove potassium from the blood. Instead, it acts as a shield, stabilizing the heart's electrical rhythm and buying the team time to solve the potassium problem. Next, we push regular IV insulin alongside D50. The insulin binds to receptors that trigger the cellular pumps, driving potassium ions out of the dangerous vascular space and into the intracellular storage. Finally, we use Kayexalate to permanently remove the ion. This exchange resin travels through the gut, trading sodium for potassium, so it can be physically excreted in the patient's stool. When the internal filter is burned out, hemodialysis or CRRT must take over, acting as a manual external filter for the blood. Knowing the biological sequence, shielding the heart, hiding the ion, and then flushing the waste, organizes a high-stakes code blue into a precise clinical protocol. We often focus strictly on plumbing and filtration, but the kidneys are also powerful endocrine organs with profound influence over the entire body. They secrete erythropoietin, which commands the bone marrow to manufacture red blood cells. When the kidneys fail, the lack of this hormone leads directly to chronic anemia. They produce renin, which dictates systemic vascular resistance and long-term blood pressure control. They also synthesize active vitamin D, which is required for calcium absorption and maintaining bone density. Renal failure disrupts more than the body's plumbing. The resulting hormonal collapse affects the heart, brain, lungs, and bone marrow simultaneously. Understanding these interconnected patterns gives you the confidence to anticipate a crash before it happens. Trust your assessments, keep pushing your clinical thinking, and we will see you next time on Super Nurse. Hey, thanks for watching my YouTube channel. Don't forget to like and subscribe and leave a comment. Let me know what topics you want to see more of and how I can help you become the super nurse you were born to be. I hope to see you here again real soon.